Okay, if we can move on to agenda item 2, strategy, and 2.1, consultation on proposal to stop commissioning any specialist fertility services. And we've got Dr. Richard Spires, please, to lead the discussion with the microphone here.
So can I just introduce Dr. Richard Spires, please, Chair, who is our clinical lead for prescribing and clinical policies. And just to make one slight amendment to the paper, in the, under 4.4, we mentioned, of course, we would wish to take this paper through the local authority scrutiny committees, but also through our patient reference group. So I'll hand over to Richard.
The paper looks at the necessary route to do a consultation that would be on whether we should stop routinely providing specialist fertility services. That's IVF as it's commonly known, but actually it's all expert specialist fertility services compared with the current provision, because we are stopping a service. Well, that's the plan, that's what the consultation is for. This requires a full consultation. There are exceptions to this, and the two exceptions to this would be for patients who are being treated for cancer with drugs or procedures liable to stop their future fertility. Nationally, we have always stored eggs, not terribly successfully if it is available, embryos or sperm, depending on the gender of the person being treated. That then did not routinely mean the patient would have IVF afterwards. They would still have to meet IVF criteria. But we have always stored, preferably embryos. The system works very well, and we currently fund the storage of either eggs or sperms or embryo, and we would continue that in cancer patients. And in cases where men who have chronic viral infections, HIV-type infections, the sperm needs to be washed to remove the infection. And again, we would fund that specialist fertility service because it's a standard public health issue, not passing on those chronic virus infections onto a female partner. But with those two exceptions, essentially, this consultation would ask the patients in the CCG whether we should continue funding IVF, basically. We have, since 2014, when the CCG developed its own policy, we started off funding 2 cycles of IVF in patients up to the age of and including age 39, and then 1 cycle of IVF in patients aged 40 to 42 inclusive. Nice guidance, and one doesn't have to follow nice guidance, it's not mandatory, it's guidance. Nice guidance at that stage said offer 3 cycles up to 39 and 1 cycle for the 40 to 42, and gave us an algorithm for calculating the cost impact of that, which would have added almost £500,000 onto our costs to both provide older patients or female patients, in this case with IVF, and go for the full 3 cycles. And actually the CCG, along with 5 other CCGs in the region with whom we actually contract these specialist services, decided that 2 cycles up to the age of 39 and 1 cycle 40 to 42 was reasonable, and that as a policy was implemented in 2014. At the same time, we were developing a new commissioning system where we took new providers. We were not necessarily satisfied with the older providers, and again, as a region, we went out to tender for new providers, and so we all got our eligibility criteria for IVF very much in line, and the only differences were the number of cycles that were being offered. Of the 10 CCGs at the time, 5 decided to offer 2 cycles up to 39, 4 said they would offer 3 cycles up to 39, and 1 decided they were not going to fund IVF at all. went out to consultation, and the response to that consultation agreed that they should not be providing it. So we have one regional CCG in our region that is already not providing. Because of the cost impact and all CCGs suffering the same sorts of financial problems, 2 more of the CCGs in our group are out to consultation, again looking at whether they should stop. What this CCG did last year was to reduce the number of cycles across the board to 1 cycle to save money. We expected that to save between 30 and 40% of the total budget, but the success rates we have been told about by our providers, specialist providers, actually that's saving no more than about 10% of the budget. Hence we're looking to stop all of this if that's the feedback from the consultation. Current budget is about 1.4 million. The expected spend is somewhat less than that, which is always good news, but we do expect to spend £1,108,000 on IVF treatment, always for people who are eligible for the treatment, meet the age restrictions, meet residential restrictions, you have to live in the CCG to benefit. And also, there are various blood tests that demonstrate whether it's likely to work, and you do have to demonstrate that this IVF is likely to work. So already there are major hurdles for patients who do go through for IVF, but we are now looking at, because of the total cost, whether we can afford this service provision compared with other services that we need to provide. We have taken this through the Clinical Policies Forum, which has about a 50% lay membership. There are 5 lay members in that who are, and have, I have to say, for many years been fully supportive of stopping IVF, but this now needs to go out to a full consultation of everybody. We will not be stopping the investigation of infertility by our local district general hospital. So the patient who is struggling to get pregnant, or a family that is struggling to get pregnant, will still go to their GP. The GP will do basic investigations, that's still funded. They can go to district general hospitals where blockages in the tubes, small hormonal problems will be dealt with. It is the next expert level up, which is basically IVF, that this consultation is.
Okay, thank you, Richard. Do we have any questions from the board for Richard, please? We've got a number of hands, so no, not at this point, sorry. If we can pass the microphone up to Dave, please.
Thank you very much, Richard. I just want to know how long will it take before these savings are realised? Because it takes quite a long time to go through all these consultations.
We're looking at potential 12-week consultation from the time that patient reference group and scrutiny go ahead. The expectation would be mid to late October. I look at Jess for that to start in 12 weeks. Takes us November, December, January. Governing body decision in February. We would expect the new policy to be in place from the 1st of April 2017, and therefore a full year effect, because patients would not be funded if they were referred to the tertiary service after the new policy came in. So essentially it's a 2017 onwards saving.
Sorry, can we come back up? To Rebecca, please.
Yes, thank you. Yeah, I think it's really important this does go to full consultation and we gain the views and listen to the views of the public and the patients. The patient reference group is obviously only one part of that, but I think it would be useful to gain their input, particularly on the consultation papers, because they particularly valuable input in how the consultation is worded and set out. I'm talking about the plain English test and making sure that we're clear. The other point I wanted to make was around, we're seeing a number of policies come through, and that's totally understandable given our financial position. But I just wanted to reiterate, because it has been said before, an plea that we ensure we're fair and equitable acceptable across the board in this, and we're making decisions based on what is fair and acceptable and not purely financially driven.
Okay, thank you, Rebecca. Chris, what's the new microphone to Jill?
I just want to ask about specific cases of patients with cancer, particularly in my case. And that's just about decoupling the storage to the actual IVF process. And obviously some patients who we think will be rendered infertile aren't rendered infertile. So this policy seeks to address those who functionally haven't been rendered infertile, but specimens are saved. And the second question that's related to that is to give clarification as to whether all store samples are fully funded for the lifetime of the patient, and whether there is a period where they're funded and then funded by the patient.
Currently storage is for 10 years post-treatment, which if you are a 2-year-old being treated is of no use to you whatsoever, so there is exceptionality built into that system. And there is a reasonable age of 23, and from the age of 23 to 10 years we store. If you had your leukemia treated at 5, the clock doesn't even start until 23, so we fund from the time you're treated to the age of 23 and then 10 years to give people a reasonable time to think about starting a family. There is a policy in place in Norfolk where they have cut that to 5 years, from 23 onwards, at which point patients are being offered a test to see if they have actually had a return of their fertility, in which case the expectation is that if they also wish to store the embryo, they pay for that storage themselves. If they are not fertile at that point, they are told very clearly you have 5 years to use the stored specimen. At the moment, because we agreed to do this so we keep paying, we have got about 300 patients already who are at the 10-year point, but nobody's checked whether they're fertile, have children, would meet IVF criteria. So as a separate policy, what we do with this stored tissue needs to be very clear to the patients who already have started storage, but also the patients who are requesting storage in the future. That's in development as a separate policy.
Thank you. I just wanted to say a couple of things. One is that we haven't included a quality impact assessment with the papers, and we should do prior to going out to consultation. Quality impact, not quality. So when we look at quality, we look at clinical effectiveness, patient safety and patient experience. So I wanted to just note that this isn't a decision that's taken lightly by any of us, but we are faced with some stark and difficult decisions in the light of our financial arrangements, and we have to think about where we best place our financial resources. So it's an incredibly hard thing to talk to the public about. So wanted to just make a note of saying that we do recognise that this will be incredibly difficult for people placed in that position.
Okay, thank you. Sorry, Vanessa, did you want to? No. Jess, please.
Just to reiterate the point that this is a draft consultation document at this point, and it needs some more information in there. And having listened to Richard, I think it would be useful to say what we are going to be doing. So we will be doing investigations, so that those who are struggling to get back and have some clarity about what they can and what they can't expect from the NHS. So I think that's something we're looking at, as well as talking to scrutiny committees and patient reference group about making this understandable and making sure that we have questions that make sense and that the government body can look at afterwards.
Jill, can you have the microphone down to H first, please, then we'll go to G and... Sorry, Delry. Liz, you've got a microphone.
Okay, this is probably a question for Jess rather than Richard, and it is just on the draft consultation being taken to the scrutiny committees. It's a point of clarification. Does that actually mean that the draft will be brought with it informal liaison meetings and looked at by interested members of the scrutiny committees, rather than it will go through all the formal scrutiny committees in public before the consultation starts? Because I'm just thinking that might affect the timescale if it's the latter option.
So I think it's a question for the chair of each committee. So we have Peterborough and Cambridgeshire, obviously, that we do dealing with, also Hertfordshire and Northamptonshire. So some of those chairs are happy to look at process plans and consultation documents informally before consultation starts, and some would like us to go to them before consultation and during consultation for feedback. So I think it's a question, it depends on the chair's decision making there. Either way, we'll be testing it with key members of each committee to make sure that they're happy with that we are doing a robust process. That's the really important thing. So when it comes back to governing body will know that we have reached those who I think do want to express an opinion, that they can judge the answer on the back of that feedback.
Okay, thank you. Judy, please, and then
Thank you. I mean, I remain wary, as we've discussed before, of this, but I'm happy for us to go out to consultation. I hope I don't need to ask it, but I hope, and particularly because we're going to have more of these coming up here in lots of areas, I hope that we can be clear that this is a genuine consultation. And I've seen too many consultations in the past where there is a massive response one way and an organisation says, well, if we consulted with you, we're going to do it anyway. There are three questions here. I think we should think about whether they're quite the right questions. The third one, in some sense, is useful but technical. The first two, do we understand why the CCG has proposed a change? And then do people agree with the proposal? So I hope we will be able to changing our minds if the public responds strongly on the second one, particularly if they understand why it was proposed in the first place. It would be really useful to get that sense from the public of a really informed decision, given the financial constraints, should we do this or not? I'm not quite sure the question's quite gets that. I think it's hard to fish out.
Which is why it's a
Yeah, so I hope, I mean, it's not easy to get right. This is a really tough call. But I hope we are doing consultation not just because we have to, because we actually want to know how the public would prioritise this service versus all the other constraints.
As a GP, spends quite a lot of time going through the criteria as they are set out on the website with prospective young families to find out if they currently fit in. I think in some ways I can see the sense of having clarity. In some ways, if you don't offer anything, that does make it clearer. But it would be nice to be a little bit clearer about what the alternative would be if we don't offer the service. So will there be any support dealing with the private providers that we have at the moment? Will we make that interaction any easier? What services like, presumably we can still do the blood tests and some of the screening procedures, and I don't know, it just seems like it's a bit all or nothing at the moment, so maybe it doesn't have to be that bad. We do see a lot of people who really struggle with the effects of infertility. It's a very devastating thing for people who aren't ill. It's the first interaction they've often had with health services. So just think a little bit more clarity when we come to consultation of what the alternative will be would might help it.
I think Richard mentioned around that the investigation stage is still going to be provided tact.
So just to highlight very rare cases where we've got families with documented genetic abnormalities who may really need fertility services in order to conceive a healthy child. And I think we should think about the rare cases before we have a blanket decision. We really have to think about a way for some families who know that they're carrying abnormal genes to be able to access services, whether that's through extra-contractual obligations or whatever else. But I think we have to think long and hard about this before we say we're removing this service. I think it shouldn't be a blunt tool. We have to think smartly about how the implications are. And that's going to come up more and more often as we have more genetic testing and we discover more families carrying abnormal genes.
Okay, I think Richard, can we pass the microphone to Peter to respond to that?
I'm not weaseling any more than I normally weasel. That is not infertility. Therefore, this policy does not apply. Managing those cases by IVF is one thing, but this is not infertility. We're talking about patients are still fertile, but they wish to choose whether to continue with pregnancy or select pregnancy. That is outside the policy that's designed to apply to 95% of patients with infertility. And with all policies, there is always an exceptional and an individual funding request system where funding can be applied for if exceptionality is demonstrated. We are a panel with loves and guidelines, a panel we decide what is and is not exceptional, because at the moment it's a tough call, but this is to deal with the infertile family who wish to get pregnant, and that's the vast majority of people coming through. You can't have a policy that covers everybody, there's no such thing, but all it's 3,000 pages long.
I think it was just completely we have a mechanism for those that rare bunch of people. I mean, but also knowing there's going to be increasing pressure on that as we detect more and more genomic.
To address Alex's point, there are basically exceptional cases that can be made for patients if there is true exceptionality, and the advice on where a patient or a couple actually should go, even if there is no NHS provision, has always been in the secondary care system who know who their private providers are, because all these people are private. So that knowledge is always available to a patient who's moving on to specialist fertility services, and it will be still available in the secondary care system. This is just about tertiary.
Okay, then my name is Jessica and we'll do recommendations.
Thank you. So I think that's been really helpful discussion about things that we need to be clear about, and additional information that we need to be provided in the consultation. Another question for Richard is around waiting lists for those who are currently on the waiting list, and what we'll be saying to them and at what point that will stop.
There is no waiting list.
Okay, clear answer, thank you. Sorry, Mark. Change the recommendations. Sorry.
I just wanted to query whether it's worth putting in what else you can buy from any equipment health service and consultation. For example, 20 district nurses. What do we need more as a health system?
Okay, so if I can move us to the recommendations, please, at the bottom of page 2. So the governing bodies are to approve the public consultation on future provision of specialist treatments. Happy to do that? Noting that there's a formatting error in Appendix 1, the line is down, and Sharon and I have discussed that. The governing bodies are to comment on the draft consultation document attached to Appendix 1 and the equality impact assessment attached to Appendix 2, which we've done. The governing body is asked to note the consultation process document attached to Appendix 3, and the governing body is asked to note the proposal to launch formal consultation in October for 12 weeks, which will be subject to discussion with the local authorities, scrutiny committees, and the patient reference group. Okay, thank you. I think this paper particularly highlights two of the values we're trying to stress in the organisation, which